Throughout my career, I've had just wonderful experiences with patients and their incredible transformation. I guess transformation is the best word because so many of our patients are struggling with this condition of obesity and diabetes. It's severely affected their health. And then by offering them effective therapy, it's truly transformative.
Bariatric surgery is not a quick fix, and it is not cosmetic surgery. It is merely a tool. And if used in conjunction with diet and exercise, long-term success is definitively achievable.
In the preoperative portion of this whole process, we actually talk to the patients of what to expect in the immediate short term after surgery. Like how long are they going to stay in the hospital, which is usually just overnight or 2 nights. We educate them with all of our resources. And what I always tell patients is if you get to the operating day and you don't know everything that you're supposed to know after, well, then we haven't done our job.
You know, we expect patients to be ambulating or up moving around the day of surgery.
I like to, in almost every patient really, to transition to a liquid type diet that's supervised and has vitamins and protein in the regimen to try to help shrink the liver, which can happen very quickly, thankfully, to make the operation a much safer process.
Well, there's several different options when someone comes in looking for weight loss surgery, and it's really a collaboration between the surgeon and the patient as to how to choose the right path. The primary ones we use today are the sleeve gastrectomy and the Roux-en-Y gastric bypass. There's also a third procedure we can offer to patients called the duodenal switch. That is actually the most effective of all the weight loss surgeries as far as maximum weight loss. The bypass and the sleeve typically on average will result in 60 to 70% of excess body weight loss, whereas the duodenal switch can result in as much as 85%, but there are some trade-offs. The bypass and the sleeve more restricts how much someone can take in their diet. The duodenal switch causes malabsorption, meaning that everything you eat does not get absorbed, and that's why it results in more weight loss, but it also puts you more at risk of having deficiencies of vitamins and minerals, and also can alter your stool patterns. Also, patients that have had a sleeve and have kind of plateaued or regained weight, it's a good option to accelerate and resume weight loss in those kind of patients.
The risk of bariatric surgery in general are a fewfold. So bleeding, any operation that we do has some degree of risk of bleeding. It turns out that from a bariatric surgeon perspective, we are much more worried about blood clots than we are the risk of bleeding. And so we will use a mild blood thinner both before and after surgery to try to prevent the risk of blood clots. And these are things we're very aggressive about trying to prevent rather than treat. Another risk, and the thing I think most surgeons and most patients worry about, is how will the areas that we have changed and divided or reconnected heal, and will they leak? Thankfully, with the equipment and the tools that we use in surgery, the risk of anastomotic leak is about 1% or less, and in most cases we can keep this much closer to 0, and so it's not as though this is a 50-50 sort of a percentage. It's a much more unusual thing.
So we're often asked if patients after bariatric surgery can take NSAIDs or non-steroidal anti-inflammatory drugs. The general answer is no. We would prefer them not to take that. Those drugs in a class are ulcerogenic. They create ulcers with chronic use. When you have bariatric surgery, you're reducing the size of the stomach and making it a lot smaller. Therefore, the risk of ulcers, in our opinion, goes way up. What kind of problems can that cause? Well, pain, problems eating, but more importantly, those ulcers can bleed and or worse, perforate or rupture, oftentimes requiring emergency surgery.
When we talk about the risk of surgery, you have to balance that with what happens if I do not do this, and what happens if I live with this obesity and I live with diabetes and hypertension.
If you talk in the alternative, well, let's not have a surgery. Well, the simple answer to that is I tell them they're 200 times more likely to die of obesity-related conditions as opposed to having a complication of surgery. And that puts it in perspective for them. And that it's much, much safer actually to have surgery than to not. What patients eat after these operations varies significantly from day one to the end of it. There's 4 phases of what we call bariatric diets. The first one really is phase 1, where they just have liquids that are unsugared. And then they go on to mushy food, and then more mushy food, and then regular food. And the misconception that patients have is that they will never be able to eat what they want. And that's not true. They can eat what they want.
The key is that you can eat healthy and can eat normally, but with smaller portions and making healthier choices, whether it be food or liquid. You know, we live in a state where tailgating and social events are important, and they're part of our culture. We definitely, by no means, want to take that away from our post-bariatric surgery patients.
Protein's very important, and so I think a lot of people in Louisiana are going to want to be able to have crawfish afterward, and you can still go to crawfish boils. You know, you can have some of these things, but again, the volume of what you're going to be able to eat is not what it was.
I mean, weight loss surgery is a very effective intervention for morbid obesity, but it's a two-way street.
Patients have to buy into lifestyle changes and a lifelong commitment.
As long as you're doing the things that we've put in place and are teaching you and keeping up with support with the BMI and the support groups that are in place for the patient, they should do well.
The interesting thing is that the patients that exercise the most end up having a little bit of slower weight loss because they're losing fat but building muscle, which is heavy. In fact, I always tell them, whatever you're doing, I want you to do more. And the transformation of all of those things and the joy that they have of basically living the life they really want is a wonderful process.
We see very dramatic changes in the health of our patient, and it's inspiring, to be quite honest with you. And that also translates into other advantages for individuals. For example, they're able to perform their work functions better, or spending more time with their family, being able to walk and exercise and do the joyful things that everybody likes to do in life.